It's funny. Usually when we talk about a medical diagnosis, there's this expectation of mechanical precision.
Right. Oh, absolutely.
Like you break your arm, you get an X-ray.
Right.
The radiograph shows that jagged white line right on the cortex of the bone, and the attending physician just points at it and goes, well, there it is.
Yep. Problem identified.
Exactly. You cast it,
Yeah.
the osteoblasts do their little job, and you move on. The problem is isolated, the intervention is direct, and, the outcome's pretty highly predictable.
Well, the clinical model really thrives on that kind of binary, doesn't it?
Yeah, totally.
I mean, broken or intact, infected or sterile.
Right.
It gives us this very clean, very algorithmic path to follow.
But then you step into the world of chronic long-term health.
Oh, yeah. That's a whole different ballgame.
Right. Suddenly that clean algorithmic path just completely vanishes into the wilderness.
It really does.
We're looking at a diagnostic and preventative landscape that is just this incredibly massive, tangled web of society, policy, commercial interests, biology, everything.
Yeah, it's messy.
Very messy. So welcome to the deep dive.
Glad to be here.
And if you are a medical student, maybe a junior doctor, a public health trainee, or an allied health professional listening to this right now, we are speaking directly to you.
Absolutely.
Today's mission is to completely unpack Chapter 11.2 of the Oxford textbook of global public health.
A beast of a chapter.
It really is.
Yeah.
We are focusing on the prevention and control of non-communicable diseases, NCDs. And we're doing that by really looking at the underlying systems.
And, this requires a fundamental shift in perspective for anyone who's been trained in that traditional medical model we were just talking about.
Oh, for sure. Because if you're working in a clinical setting,
your daily reality is treating the pathology of the individual sitting right in front of you.
Exactly. You're managing the immediate crisis.
Right. But to actually grasp the epidemiology of NCDs, we have to zoom out. We need to look at the environment that created the patient in the first place.
I love that phrasing, the environment that created the patient. I want you to imagine a waterfall for a second.
Okay.
Treating a non-communicable disease like, say, a myocardial infarction or a late-stage carcinoma once it has already developed.
Yeah.
It's basically like standing at the bottom of a rushing waterfall, desperately trying to pull drowning people out of the river.
That is exactly what it feels like in the ER.
Right. You're exhausted. The critical care system is operating way over capacity. And honestly, no matter how many people you intubate or stent,
more just keep falling in.
Exactly. More keep falling in. Public health, and specifically NCD prevention, is about hiking upstream and redesigning the bridge so people do not fall into the river in the first place.
Upstream architecture.
Yes. Today, our guiding metaphor is exactly that. Prevention as upstream architecture.
I like that. And to truly conceptualize this upstream architecture, we are going to need to build a framework today.
Let's do it.
I want you to keep this pathway anchored in your mind as we go. Risk leads to exposure.
Okay.
Exposure leads to outcome.
Right.
Outcome necessitates intervention, and intervention drives system impact.
Risk, exposure, outcome, intervention, system impact. Got it.
Because if our entire healthcare apparatus only focuses on the outcome, the end-stage disease stage,
The system is just going to collapse under its own weight.
inevitably, we must interrogate the risk and the exposure that are just embedded deep within our physical and commercial environments.
Okay, let's unpack this, because to understand where we're going with this architectural redesign, we first really need to look at the exact historical moment the world's quote-unquote architects finally realized that the bridge upstream was broken.
Ah, yes, the paradigm shift.
Right, we're talking about a major shift in global health priorities. So let's rewind to September 2011.
September 2011 represents a total watershed moment in the history of global health governance.
What happened?
The United Nations convened a high-level meeting specifically dedicated to non-communicable diseases.
Okay.
And we're talking about heads of state, finance ministers, senior government functionaries from across the entire globe gathering in the General Assembly.
Which is a big deal, right?
Oh, it's huge. What makes this so historically significant is the absolute rarity of the event.
Really?
Yeah. Prior to 2011, the UN had only convened a health-related meeting of this geopolitical scale one other time in its entire history.
Wait, really? Just one?
Just one.
That was the 2001 summit to frame a global response to the HIV/AIDS epidemic, right?
Exactly. So the adoption of a political resolution on NCDs in 2011, it meant the global community was officially elevating chronic diseases to the exact same existential threat level as the HIV/AIDS crisis.
Wow.
It was an acknowledgement that the global health apparatus had to completely pivot.
Okay, wait. I have to push back here for a second.
Go for it.
Because the UN traditionally convenes for sudden explosive crises.
Right.
Earthquakes, wars, rapidly spreading infectious outbreaks like Ebola or SARS.
Right. Very true.
But NCDs, by definition, they build up over decades. It's the slow, quiet accumulation of arterial plaque or the gradual decline of pancreatic beta cell function,
Right.
or the silent progression of cellular mutation. So why did it take until 2011 for the UN to wake up to this?
It's a great question.
Because if you look at the epidemiological data, tobacco alone killed roughly 100 million people in the 20th century.
Staggering numbers.
Yet NCDs and tobacco control were completely absent from the Millennium Development Goals established in 2000.
Yep.
How did the global health community just miss a century-long epidemic?
Well, the historical lag really speaks to a deeply entrenched bias in the foundations of global public health.
An infectious bias.
Exactly. For centuries, the primary existential threats to human populations were communicable pathogens: cholera, tuberculosis, malaria, smallpox.
Or acute killers.
The entire architecture of global health, the very foundations of epidemiology laid down by figures like John Snow, they were explicitly built to track and contain infectious agents.
Ah, that makes sense.
So in the year 2000, when the Millennium Development Goals were drafted, the focus remained overwhelmingly on infectious diseases, maternal mortality, and child malnutrition.
Especially in lower-income nations, I'd imagine.
Exactly. The infrastructure was simply not designed to look at multi-decade risk accumulations.
It's almost as if the global health community had a massive institutional blind spot.
They absolutely did.
Like they were so hyper-focused on the mosquito vectors and the viral loads that they completely missed the cigarette, the sedentary built environment, and the ultra-processed food supply.
That is a perfect way to put it. Even though epidemiological transitions showed NCDs had already become the leading cause of death globally by the late 20th century.
The global funding and attention just were not there.
No. And the prevailing assumption among global health policymakers at the turn of the millennium was that NCDs were just a quote-unquote disease of affluence.
Oh, like a rich person's problem.
Right. The mindset was essentially, NCDs are a problem for wealthy, aging populations in the global north. Let the high-income countries handle their heart disease. We need to focus our international resources on malaria and HIV.
But the data didn't support that, did it?
Not at all. The demographic and epidemiological data emerging between 2000 and 2015 completely shattered that narrative. The burden was shifting rapidly.
So what changed?
When the global community transitioned from the Millennium Development Goals to the post-2015 Sustainable Development Goals, the SDGs, the drafting groups, finally acknowledged a harsh reality.
Which was?
You simply cannot achieve sustainable human economic development without aggressively preventing NCDs. So they were formally embedded into SDG Target 3.4.
Okay, so the UN finally recognizes the problem and writes it into the SDGs.
Yes.
But that brings us to a really fascinating linguistic and conceptual hurdle. What exactly is the problem they're defining?
The nomenclature.
Right. Let's talk about the name itself, non-communicable diseases.
Well, according to the World Health Organization, for the purposes of these global summits and tracking targets, they restricted the operational definition of NCDs to the big four disease groups.
Okay, what are the big four?
Cardiovascular diseases, which encompasses ischemic heart disease and cerebrovascular disease,
Right.
diabetes, various cancers, and chronic respiratory diseases like asthma and chronic obstructive pulmonary disease.
Okay, so cardiovascular, diabetes, cancer, chronic respiratory. And these big four disease categories are linked by the big four modifiable risk factors, right?
Correct. Tobacco use, unhealthy diet, physical inactivity, and harmful use of alcohol.
Okay, I have to be honest here. As a clinician, calling them non-communicable feels technically flawed.
I mean, you're not wrong.
Right. If we look at the etiology of certain major cancers, cervical cancer is directly linked to the human papillomavirus.
HPV, yes.
Hepatocellular carcinoma is heavily linked to hepatitis B and C infections.
Exactly.
Those are viral pathogens. They are absolutely communicable.
They are.
And even from a broader upstream public health perspective, aren't multi-million-dollar corporate marketing campaigns for sugar-sweetened beverages and cigarettes a form of communicating a disease vector?
That's a great point.
I mean, they are literally transmitting risk behaviors across borders via mass media.
They are, and the descriptor non-communicable really just emerged purely as a negative definition.
What do you mean?
It simply meant not infectious in origin and spread. It was coined during an era when infectious diseases were the dominant focus of medicine.
Oh, I see.
But your point about the infectious origins of certain cancers highlights the messy reality of biological taxonomies.
Right.
And more importantly, your point about corporate marketing taps into a major debate within the socio-epidemiological community.
Oh, really?
Yeah. If we define a vector as an agent that carries and transmits a disease to a living organism,
Which is the textbook definition.
right, then multinational corporations aggressively marketing ultra-processed foods into emerging economies operate very much like a vector. Behaviors change under the intense influence of cultural and commercial messages that are highly communicable.
So why not just use a more accurate term? Because you often hear the phrase lifestyle-related diseases thrown around in media and even in some clinical settings.
Oh, man. Labeling these conditions as lifestyle-related diseases is highly problematic from a public health standpoint
Why is that?
because it places the burden of disease squarely on the individual.
Oh,
It implies that developing type 2 diabetes or essential hypertension is simply a moral failure of personal willpower.
right, like you just didn't try hard enough.
Exactly. It completely ignores the social, economic, and commercial determinants, that upstream architecture we were talking about, that operate at the population level and heavily constrain individual agency.
Yeah, if you live in an urban food desert where the only accessible, affordable calories are highly processed and nutrient poor,
And your neighborhood lacks safe infrastructure for walking.
your lifestyle choice is heavily overridden by your environment. It's essentially victim blaming masquerading as a benign medical category. You're penalizing the patient for drowning when someone else pushed them off the bridge.
That is exactly what it is. And because of that, some public health experts have proposed alternative acronyms to shift the focus back to prevention and systemic causes.
Like what?
One prominent proposal is the DITA disorders, DITA,
DIT. What does that stand for?
diet, inactivity, tobacco, and alcohol-related disorders.
Oh, I thought.
Right. It directly names the root behavioral causes rather than the end-stage pathology.
That makes so much more sense.
It tells policymakers exactly what exposures need to be countered to reduce the population burden.
So DIT shifts the cognitive frame from managing the end-stage disease in a hospital bed to regulating the upstream exposures in the community.
Exactly.
But looking at the literature, the UN and the WHO didn't adopt DIT.
No, they didn't. And this raises an important point about system impact and the friction between scientific precision and political reality.
Politics always gets in the way.
It does. Despite all its technical flaws and negative phrasing, NCDs is the term that the 2011 UN summit legitimized.
Right.
It's the nomenclature that finally registered on the consciousness of presidents, prime ministers, and global finance ministers.
So it holds the political capital necessary to secure funding and drive international treaties.
Exactly. So the global public health apparatus essentially has to accept the flawed term just to keep the momentum going.
We have to play the hand we're dealt to keep the funding streams open.
Yeah.
Even if it means conditions that are undeniably non-communicable like severe mental illness, vision and hearing disorders, musculoskeletal injuries, they kind of get sidelined in the global targets because they don't perfectly fit the WHO's restricted Big Four definition.
It's an unfortunate reality. We work within this established framework while continuously advocating for a broader, more inclusive understanding of chronic health.
We use the politically recognized term to secure the resources to build the bridge, even if we know the architectural blueprint isn't perfectly comprehensive yet.
Well said.
Okay, so we have the definition established. Now we need to map the sheer scale of this issue. We need to understand the global burden, and more importantly, who is actually suffering the most.
And the epidemiological data here completely defies those early assumptions about NCDs being a disease of affluent retirees.
Right. So what do the numbers actually look like?
The statistics present a monumental challenge to global health systems. The WHO estimated that in 2008, NCDs accounted for 36 million deaths,
36 million.
which represents 63% of all mortality worldwide.
Over half.
Yeah. And by 2010, the global burden of disease study showed NCD mortality had actually increased to 65% of total global mortality.
Wow. And it's not just the mortality, right? The economic impact has to be massive.
Oh, it's staggering. A joint macroeconomic study by the World Economic Forum and the Harvard School of Public Health estimated that NCDs and mental illness would cost the global economy $47 trillion in lost output between 2011 and 2030.
$47 trillion.
Trillion, with a T.
That is a number so astronomical it almost loses its conceptual meaning.
It's hard to wrap your head around.
But here is the specific statistic from the Oxford textbook that I think completely shatters that old stereotype we talked about.
Which one?
80% of NCD-related deaths occurred in low- and middle-income countries, LMICs.
Yep.
And even more critically, 90% of the NCD attributable deaths that happen prematurely, and they define premature as death before the age of 60, occur in those LMICs.
Yeah. When we compare disease burdens across different global regions, we have to be very precise with our statistical measures.
How so?
Well, when we look at absolute numbers of deaths, LMICs naturally account for the vast majority simply because they hold the lion's share of the global population.
Right. The denominator is massive, so the absolute body count is highest there.
Exactly. However, high-income countries still currently exhibit higher proportional mortality rates.
Meaning what, exactly?
Meaning, out of all the people who die in a wealthy country in a given year, a higher percentage die from NCDs compared to infectious causes.
Oh, I see.
But, and this is the crucial epidemiological pivot, because so many deaths in LMICs happen at much younger ages, LMICs actually demonstrate higher age-standardized mortality rates for NCDs compared to high-income nations like the US or the UK.
Okay, let's clearly define that concept of age-standardized mortality, because that's a really vital concept for our listeners.
Sure.
You're saying that if you mathematically control for the age distribution of the populations, like if you artificially level the playing field so you aren't just seeing the effect of wealthy countries having older populations,
Right.
a 50-year-old living in a low-income country is actually at a significantly higher risk of dying from an NCD than a 50-year-old living in a high-income country.
The data unequivocally supports that. NCDs are not just a disease of the elderly in wealthy nations.
Clearly not.
We are observing massive losses in what health economists call disability-adjusted life years, or DALYs, in prime working age populations in LMICs.
Ah, dailies. Let's break that down.
DALYs are a vital metric because they capture the full burden of disease. 1 DALY equals 1 year of healthy life lost.
So it measures not just the years of life lost to premature death, but also the years lived with profound disability.
Exactly, like blindness from diabetic retinopathy or paralysis following a stroke. Between 1990 and 2010, the daily loss from diabetes alone rose by 69% globally.
69%.
Yeah, and that increase was heavily concentrated in developing economies.
Which brings us to perhaps the most profound systemic insight in this entire chapter.
The epidemiological transition.
Yes. Specifically, the transition known as the reversal of the social gradient.
It's a fascinating phenomenon. The trajectory of an NCD epidemic within a society is not static at all.
Right.
It mutates dynamically as the country undergoes economic and structural transitions.
I was actually reading the textbook's breakdown of this, and it immediately sparked an analogy for me.
Oh, yeah.
Yeah, it's remarkably similar to the adoption curve of new consumer technology.
Okay, I can see that.
Think about the introduction of the very first mobile phones or early flat-screen televisions.
Super expensive.
Exactly. In the beginning, only the wealthiest segment of society can afford them.
Right.
Similarly, in the very early stages of an economic transition in a developing country, it's actually the affluent who have the financial luxury of adopting harmful behaviors.
That's right. They possess the disposable income to purchase imported high-fat processed foods.
Yeah.
They can afford manufactured cigarettes. They buy motorized transport and transition away from manual labor, adopting a highly sedentary lifestyle first.
So the initial phase of the epidemic sees the higher socioeconomic groups at the highest relative risk.
Yep. The data from early transition economies consistently shows higher rates of obesity and early cardiovascular markers in the urban wealthy.
But as the economy develops, the structural environment rapidly shifts.
Right.
Just like the technology adoption curve, those harmful products eventually become hyper-industrialized. They are mass-produced for mass consumption.
Unit economics drop.
Exactly. The unit economics drop, and the products become ubiquitous and cheap. Everyone has a smartphone, and everyone has access to cheap processed food.
And that inflection point is exactly when the social gradient reverses.
How so?
The affluent and highly educated populations eventually leverage their wealth and health literacy to pivot away from the risk.
Oh, I see.
They purchase premium, unprocessed foods. They join fitness clubs. They access routine preventative health care and screening.
They respond to public health campaigns and quit smoking.
Exactly. The risk environment for the wealthy improves. But the marginalized, poorer, and less educated populations become the primary targets.
Because they're the most vulnerable to the industrialized risk.
Absolutely. Because the absolute cheapest, most calorically dense, and most accessible foods in their immediate environment are now ultra-processed.
And the tobacco industry aggressively pivots its marketing to target lower-income demographics with cheap, heavily subsidized products.
Exactly. Plus, their built environments are often highly stressful, lacking safe green spaces for physical activity, and subject to higher levels of ambient air pollution.
So the ubiquitous presence of cheap tobacco, aggressively marketed alcohol, ultra-processed foods, and a built environment hostile to physical activity.
It essentially writes a structural prescription for mass epidemics among the poor.
They experience the highest burden of disease.
And simultaneously, they possess the least financial and geographical access to the costly, technology-intensive medical care required to manage those diseases once they manifest.
Right. A diagnosis of a chronic NCD in these populations frequently results in catastrophic out-of-pocket health expenditure.
Which just pulls entire extended families deeper into generational poverty.
This reversal of the social gradient perfectly illustrates why prevention cannot simply be an educational pamphlet advising people to, eat better and exercise.
No, it must address the upstream architecture.
So, if the poorest and most vulnerable demographics are suffering due to unavoidable mass exposure in their environment, how do we fundamentally intervene?
Well, to answer that, we have to completely dismantle how clinicians traditionally view the concept of risk.
Okay, here's where it gets really interesting. Let's talk about redefining clinical risk.
To architect a comprehensive public health response, we must examine the biological and epidemiological reasoning behind cardiovascular disease risk, or CVD risk.
Okay.
Because the principles governing CVD apply broadly to the prevention of almost all major NCDs. Jeffrey Rose, a pioneer in public health, laid out the foundational theories here.
Rose's principles.
Right. We need to establish 4 core epidemiological principles of risk.
Let's break these down. What is principle number 1?
Principle 1. Risk operates in a continuous manner across the biological spectrum, not across arbitrary human-defined thresholds.
Okay, let's pause right there. Because as a medical student or a junior doctor, your entire training is built on diagnostic algorithms.
Oh, absolutely.
You are taught that you diagnose essential hypertension and initiate pharmacological treatment when a patient's blood pressure crosses a very specific threshold.
Right, traditionally something like 140/90.
But the epidemiology is telling us the biological risk doesn't just magically switch on at 140.
Not at all. Biological variables. Yes. Principle 2. The vast majority of adverse clinical events in a population arise from people who sit in the mid-range of a risk factor distribution, not the extremes.
Okay, so to translate that, the majority of myocardial infarctions and cerebrovascular accidents do not happen to the patients with the most extreme sky-high blood pressures or the rare genetic dyslipidemias.
Correct. While having an extremely elevated risk factor, say a systolic blood pressure of 180 places a specific individual at a drastically higher relative risk of an imminent stroke.
Yeah.
There are simply very few people in the overall population who actually walk around with blood pressure that high.
Right, they're the outliers.
Exactly. If you plot the population on a bell curve, the vast majority of people sit right in the middle.
Okay.
And because that mid-range group is so massive in absolute numbers, even a very moderate biological risk, when applied to millions of people, results in the largest absolute number of deaths.
Oh, wow. The textbook actually highlights a staggering statistic here.
The blood pressure stat.
Yeah. Half of all blood pressure-related deaths occur below the traditional clinical threshold of 14/90.
It's incredible.
Half of the mortality burden is happening in people who wouldn't even be officially diagnosed with hypertension under standard primary care guidelines.
Exactly. Therefore, a health system that only screens for and treats the extremes will inevitably fail to prevent the bulk of the population burden.
Makes sense. What is principle number 3?
Principle 3 dictates that when multiple risk factors coexist within the same patient, the overall risk is additive and often synergistic.
Okay, so a moderate smoking habit combined with mildly elevated LDL cholesterol and a borderline blood pressure of 135/85.
Creates a compounding equation of vascular risk. It's not just 1 + 1 + 1.
Got it. And finally, principle 4.
Principle 4 synthesizes the previous 3. In all populations, the absolute majority of cardiovascular events arise in individuals who present with concurrent mild elevations of many risk factors, rather than in individuals possessing a profoundly high level of a single isolated risk factor.
So the typical patient presenting to the ED with a sudden STEMI is often the person with a blood pressure of 135/85, slightly elevated lipids, who carries a bit of visceral adiposity and works a sedentary job.
Exactly. It is not necessarily the genetic outlier.
So what does this continuous risk framework dictate for our upstream architecture?
Well, it demands that we sharply differentiate between high-risk individual clinical management, which relies on physicians prescribing targeted drug therapy, and population-level public health intervention.
Because if the biological risk begins rising at 11-10-70, we can't possibly put the entire global population on ACE inhibitors and statins.
No, that would be medically dangerous due to polypharmacy risks, and it's just economically absurd for any health system to sustain.
Right, so we have to address the millions of people sitting in the mid-range of the bell curve.
Exactly, and the only effective way to do that is to shift the entire population's distribution curve to the left.
Shift the curve to the left. How do we do that?
If a government implements structural changes, such as drastically reducing the hidden sodium content across the entire commercial food supply, they can lower the average systolic blood pressure of the entire nation by perhaps 2 or 3 millimeters of mercury.
Okay, but on an individual level, a 2-millimeter drop seems clinically irrelevant, right?
For one person, yes.
Yeah.
But across a population of 50 million people, that tiny shift to the left prevents tens of thousands of strokes and heart attacks annually.
Oh.
It vastly outperforms the strategy of simply giving strong antihypertensives to the small percentage of patients over 160/100.
That is the defining philosophy of public health right there. Population-level structural interventions objectively outperform individual-only clinical strategies.
Absolutely. Small reductions in risk exposure achieved uniformly across the whole population yield massive public health victories.
It's the architectural difference between building a sturdier bridge for everyone versus throwing life preservers to the few who fall in.
Exactly. And this continuous risk framework is universal. It applies to shifting the population mean for body mass index to combat diabetes,
Right.
lowering ambient particulate matter to reduce chronic respiratory disease, and denormalizing tobacco to prevent oncology burdens.
It is the scientific justification for population-based policy.
It is.
So if the epidemiological mandate is to shift the population curve to the left, we need the actual architectural plans. We need to know what materials build a better bridge.
Right.
This brings us to the global blueprint and the tools of policy. Following the 2011 UN summit, what is the overarching global framework?
The World Health Assembly approved a comprehensive global action plan for NCDs. The headline aspiration is widely known as the 25 by 25 goal.
25 by 25, what does that mean?
The target is to achieve a 25% relative reduction in overall premature mortality from NCDs by the year 2025.
Okay, so to make that actionable, they establish a set of 9 voluntary global targets, right?
Yes, they quantified exactly what shifting the curve looks like on a global scale.
So we're talking about targets like a 30% relative reduction in the mean population intake of sodium,
A 30% relative reduction in current tobacco use,
a 10% reduction in physical inactivity,
a 10% reduction in the harmful use of alcohol.
and halting the global rise in diabetes and obesity.
Setting targets provides the metric for success, obviously, but the real architectural work lies in the policy tools deployed to actually achieve them.
Because, as we established with the reversal of the social gradient, behavior is profoundly shaped by the built environment and commercial regulation.
Right. You cannot educate your way out of a systemic, structurally reinforced problem.
So what are the tools?
To that end, the WHO identified a suite of highly cost-effective evidence-based interventions. They're frequently referred to as the public health best buys.
Let's examine these best buys, because this is the exact intersection where public health leaves the clinical hospital setting and enters the legislative parliament building.
Exactly. For tobacco control, the best buys are enshrined in the Framework Convention on Tobacco Control, or FCTC.
What's the most powerful tool there?
Macroeconomic. Drastically reducing affordability by implementing high excise taxes.
Hitting them in the wallet.
The behavioral economics are crystal clear. Demand for tobacco, especially among youth and lower income demographics, is highly price elastic. Raising the price directly reduces consumption.
Makes sense.
The framework also mandates creating completely smoke-free environments by law in all indoor workplaces and public spaces.
Which denormalizes the behavior and protects against secondhand exposure.
Right. Furthermore, it requires comprehensive legislative bans on all forms of tobacco advertising, promotion, and corporate sponsorship.
And I imagine the regulatory approach for alcohol shares similar architecture.
Very similar. Implementing excise tax increases, enforcing comprehensive restrictions on marketing and advertising, and strictly regulating the physical availability and retail hours of alcohol.
Okay, what about diet and nutrition? Because that seems harder to regulate.
It is. When we turn to diet and nutrition, the policies have to move beyond mass media education campaigns. The most effective interventions involve government-led food reformulation.
Give me an example of that.
A prime example is legally mandating the removal and replacement of artificial trans fats, partially hydrogenated oils, with polyunsaturated fats across the entire commercial food supply chain.
Okay, I want to pause here for a really important analytical checkpoint.
Sure.
Because when we discuss leveraging taxation to alter behavior, when we talk about governments banning corporate advertising, or legally dictating to a food manufacturer the specific lipid profile they're allowed to use in their products, we are stepping into highly charged political territory.
Oh, absolutely.
There's a robust, ongoing global debate concerning free markets, personal liberty, the philosophy of the nanny state, and the boundaries of government overreach.
Right.
Many argue that corporations should be free to manufacture legal products, and adult consumers should be free to purchase them without punitive taxation or state interference.
That tension is the fundamental political reality of public health policy. Public health inherently balances individual liberty against collective well-being and the economic burden on state health systems.
And to be clear to our listeners, we are not taking a philosophical side on the ideological debate of free markets versus state intervention.
No, not at all.
We are simply analyzing the epidemiological evidence presented in the Oxford textbook.
Right.
And strictly from a data-driven biological perspective, the evidence shows that voluntary industry, self-regulation like asking food companies to voluntarily reduce salt or asking alcohol companies to voluntarily market responsibly, historically fails to shift the population risk curve to the left.
The data overwhelmingly demonstrates that these multi-sectoral regulatory governance tools like taxation and legislative bans are unequivocally the most cost-effective methods for reducing population exposure.
It's an objective analysis of system impact.
Exactly. If the mandate of a health minister is to reduce the millions of dailies lost to cardiovascular disease, utilizing excise taxes and regulating trans fats provides the highest biological return on investment.
But the health minister doesn't control taxes.
Right. And that is what makes this so complex. The levers of health are held by ministries far outside of healthcare.
Explain that.
To build this upstream architecture, you need the finance ministry to implement taxes. You need the agriculture ministry to shift subsidies to make fresh produce economically competitive with ultra-processed grains.
Right.
You need urban planning and transport ministries to design safe pedestrian pathways, protected cycling infrastructure, and efficient public transit to naturally engineer physical activity back into daily life.
So it's an entirely interconnected system. Health is created in the city planning office, not just the clinic.
Exactly.
But let's pivot to the clinical reality on the ground. Policy is the necessary upstream architecture, absolutely.
Yeah.
But the health system still exists downstream. The hospitals are still there, and they still have to catch the millions of people who have already fallen into the river, who have already developed chronic NCDs.
Yes, they do.
How do under-resourced health systems cope with this incoming tide? This leads us to the monumental challenges of health system reconfiguration.
The transition from acute to chronic care presents a staggering logistical and financial hurdle, particularly for LMICs.
Because these health systems are frequently operating under severe constraints already.
Exactly. They are still actively battling the uncompleted agenda of communicable diseases, managing HIV antiretroviral programs, treating multi-drug-resistant tuberculosis, controlling malaria.
And they're simultaneously trying to expand maternal and child health services.
Right. This is the infamous double burden of disease.
So, if an LMIC health ministry is already stretching its budget to contain a sudden cholera outbreak, how can they possibly afford to establish the lifelong, continuous, highly technical clinical care pathways required for millions of citizens developing type 2 diabetes and ischemic heart disease?
Well, the short answer is they cannot achieve it using the traditional high-income country model.
The model that relies on specialized physicians working in expensive tertiary care hospitals.
Exactly. That model is too brittle and incredibly resource-intensive. The entire system must fundamentally reconfigure.
What's the first step?
The foundational step is integration. NCD care must be seamlessly integrated into the broader framework of universal health coverage, or UHC, at the primary care level.
Okay, so health systems cannot afford vertical siloed disease programs.
Exactly.
Right? You can't have a system where a patient walks for a day to a rural clinic that only performs HIV testing on Tuesdays and then has to find a completely different clinic to manage their hypertension on Thursdays.
It has to be comprehensive primary care.
Makes sense.
And because there is a critical global shortage of specialist doctors and general practitioners, especially in rural LMIC settings, the system must structurally rely on concepts known as task shifting and task sharing.
Let's delve into the mechanics of that.
Yeah.
How does task shifting actually operate without compromising patient safety?
Well, task shifting involves the rational redistribution of specific clinical tasks from highly qualified, scarce health workers like specialist endocrinologists or cardiologists to health workers with shorter training and fewer formal qualifications.
But they are specifically trained for those protocol-driven tasks, right?
Exactly. We are talking about empowering non-physician healthcare providers, such as specialized nurses, allied health professionals, and community health workers, to screen, detect, and routinely manage stable NCDs.
The textbook actually highlights a phenomenal case study of this, the Bavar's worker model in the Islamic Republic of Iran.
Oh, the Bavar's system is a masterclass in primary care architecture.
Tell us about them.
The Bavars are community health workers recruited directly from the local villages they will serve.
Which provides immense cultural competence and deep community trust.
Right. Following rigorous, targeted training, they operate from rural health houses. Studies consistently demonstrate they are highly effective at screening the population for hypertension.
They utilize basic point-of-care glucometers to monitor blood sugar.
They provide culturally appropriate lifestyle counseling and, crucially, ensuring long-term medication adherence.
And for protocol-driven management of stable diabetes and hypertension, their clinical outcomes actually rival those of specialized physicians.
Yes, completely bypassing the massive bottleneck of waiting for an urban specialist.
It is essentially democratizing the delivery of healthcare.
It really is.
But having the personnel is only half the equation, right? You cannot manage a patient's hypertension if you do not have the physical medication to give them.
Which brings us to the critical vulnerability of the supply chain. System impact for chronic disease relies entirely on continuous, uninterrupted access to essential drugs and basic diagnostics.
And for NCDs, which require lifelong daily pharmacological management, affordability is the absolute defining metric.
It is. In many LMICs, purchasing a 1-month supply of standard blood pressure or diabetes medication out of pocket can consume a massive fraction of a family's monthly wage.
Leading to inevitable non-adherence.
Exactly.
So the system response has to ruthlessly prioritize the procurement of generic drugs.
Generic substitution is absolutely essential. Leveraging the massive manufacturing capacity of countries like India, China, and Brazil is crucial to driving down unit costs.
But beyond just relying on market forces, health ministries need to utilize the mechanism of pooled procurement.
Pooled procurement is vital.
For those unfamiliar, this involves multiple sovereign nations or large regional blocs banding together to consolidate their purchasing power.
Right.
They approach multinational pharmaceutical companies to buy medications in massive, multi-year bulk orders, allowing them to negotiate significantly lower prices than they ever could individually.
Yes, and ensuring that these negotiated drugs are formally listed on the country's national essential drug list, guaranteeing they are prioritized for public funding.
What about diagnostics?
Primary care infrastructure needs low-cost, robust point-of-care diagnostics. We need simple...
Okay, so we have mapped the history, the biological definitions, the staggering global burden, the continuous risk models, the overarching policy tools, and the necessary health system reconfigurations.
We've covered a lot of ground.
Bringing all of this together, can this upstream architecture actually be built? I mean, is there empirical proof that we can shift the population curve to the left?
The epidemiological evidence is unequivocal. We have historical population-level proof.
We know it works because we have seen it executed. The textbook cites the North Karelia project in Finland, which is arguably one of the greatest public health victories of the 20th century.
Oh, North Karelia is legendary.
In the 1970s, the North Karelia region had the highest cardiovascular mortality rate in the entire world.
Middle-aged men were dying of massive heart attacks at an astonishing rate.
The risk factors were heavily embedded in the culture and the environment, right? Diets extremely high in saturated fats from dairy and butter, massive sodium intake, and high rates of smoking.
And their intervention was a masterclass in multi-sectoral upstream architecture. They didn't just build more cardiac intensive care units.
They engaged the entire community.
Right. They collaborated directly with local agricultural sectors to convince dairy farmers to transition to growing berries and producing rapeseed oil.
They worked with local butchers to reformulate traditional sausages to contain significantly less sodium and fat.
They utilized massive community-based education, enlisting local women's organizations and schools.
And over the ensuing decades, they completely halted and reversed the epidemic. Cardiovascular mortality plummeted by over 80%.
80%, it's amazing.
And it was achieved not by miraculous new heart surgeries, but by structurally shifting the entire population's risk curve through environment and diet.
And we have seen similar massive declines in lung cancer incidence in nations that enacted aggressive taxation and indoor smoking bans.
We have seen cervical cancer rates collapse following the implementation of organized, population-wide HPV vaccination and screening programs.
The historical lesson is clear. Massive reductions in disease burden do not derive solely from costly clinical interventions at the end of the disease process.
The vast majority of the decline in NCD mortality observed in high-income countries over the last 50 years is directly attributable to risk factor reduction and structural changes at the population level.
Exactly.
So what does this all mean for us today? It means the scientific knowledge is established. We possess the blueprints. We know exactly how to redesign the bridge.
It is entirely a matter of political will, cross-sector coordination, and structural execution.
And as we close this analysis, I want to leave you with a final thought to mull over. Let's circle back to the socio-epidemiological model of risk we discussed earlier.
Okay.
If we accept the premise that risk factors like ultra-processed foods, sugar-sweetened beverages, and commercial tobacco are essentially communicable through sophisticated marketing and global trade,
Operating as the modern commercial vectors of disease.
if we accept that reality, should public health professionals and global regulatory bodies begin treating multinational corporate advertising campaigns and trade lobbying with the exact same aggressive containment strategies that epidemiologists use against mosquito breeding grounds in a malaria outbreak?
That is the million-dollar question. Is the future of public health less about practicing medicine within the four walls of a clinic and increasingly about corporate regulation, international trade law, and the fundamental restructuring of our global food and economic systems?
That is a profound question to sit with. Is the most effective doctor of the future actually a trade lawyer, an agricultural economist, or an urban planner?
Food for thought.
Thank you for taking this deep dive with us today. To consolidate your learning and reinforce these concepts, we're going to transition into our rapid recall prompts.
Let's see what's stuck.
I will ask a question based on today's material, and there will be a brief pause. Try to mentally lock in the answer before I reveal it. Ready? Ready. Prompt 1. Which specific global health event in 2011 marked a paradigm shift, placing NCDs on the same priority level as a major 2001 summit did for HIV/AIDS? Take a second.
The answer is the UN High-Level Meeting on Non-Communicable Diseases.
Prompt 2. The WHO originally restricted the operational term of NCDs to 4 major disease groups. What are they? Think about the big 4.
They are cardiovascular diseases, diabetes, cancers, and chronic respiratory diseases.
Prompt 3. What happens to the social gradient of NCDs as an epidemic matures within a transition economy? Give it some thought.
It reverses. Initially affecting the affluent, the burden shifts disproportionately to the poorer and less educated demographics who are most exposed to mass-produced, industrialized risks and have the least access to preventative care.
Prompt 4. According to Jeffrey Rose's principles of continuous risk, why do the absolute majority of adverse cardiovascular events in a population occur in people with mid-range risk factor levels rather than extreme high levels? Recall the curve.
Because biological risk operates continuously, and the vast majority of the population mathematically falls into the mid-range of the bell curve, creating a much larger absolute number of clinical events, despite a lower relative individual risk.
Prompt 5. What is the specific operational strategy involving non-physician healthcare providers, like specialized nurses or community BVARS workers managing routine, stable NCDs, to overcome severe workforce shortages in LMICs? Take a second.
The answer is task shifting, or task sharing.
Prank 6. Which WHO Global Action Plan target aims for a specific reduction in premature NCD mortality? And what is the target percentage and target year? What's the catchphrase?
It's the 25 by 25 goal, a 25% relative reduction in premature mortality by the year 2025.
Great job. To truly solidify these frameworks, we strongly advise you to read Chapter 11.2 of the Oxford Textbook of Global Public Health alongside this discussion.
Pay special attention to the subsections on risk factors and determinants and a comprehensive response.
That will really help firmly anchor your understanding of continuous risk biology and structural prevention. Here are the details of this episode.
NCD Prevention.